We have Elizabeth Hunefeld from our cardiology clinic, who was kind enough to step in for Dr. Carr, who has the flu, even after getting a flu shot 2 weeks ago. Then we have Dr. Darren Alcock, who's an endocrinologist and hypertension specialist at our endocrinology clinic. Ashton Cohn is a nurse at our wound care center. Carla Glaus is our certified diabetes educator at our diabetes center. And Marietta Dunaway is a dietitian that works at both our diabetes center and at Health Point. So,
one question or one suggestion. Would each one of you stand up as Mike? Let's read it.
Okay, do that again so people in the back can see. Yeah, sure, we got a lot of people. So Elizabeth Hunefeld, this is Elizabeth from the cardiology clinic. Sorry, like I say, this is new having this many people. Dr. Darren Alcock, who's our endocrinologist and hypertension specialist. Ashton Cohn from the Wound Center. Carla Glaus from the Diabetes Center. And Marietta Dunaway, dietitian.
Okay, I've got a couple of questions within a question. The first part is, what causes glucose to become high? Is it diet, genetics? In the beginning, what first causes it to rise?
The risk factors for diabetes can be family history, inactivity, maybe just not watching your diet very well and gaining extra weight. If you're carrying a little extra weight around, you may have a history of hypertension, high cholesterol. So those are the risk factors. And so we want to reduce those risk factors through lifestyle modification. So watching your diet, reducing your portions, moving more. The American Diabetes Association recommends 30 minutes, 5 days a week of staying active, riding a bicycle, taking a walk. So that's some place where you can start. And then, sometimes medication is needed. And then education, of course, is the cornerstone of all of that.
Carla, I've got a quick question on the 30 minutes, five times a week. So with those 30 minutes, can they break those 30 minutes up?
Yes, you can break those 30 minutes up, maybe 10 minutes in 3 segments through the day, or 15 minutes in the morning, 15 minutes in the evening. Any way to get moving and staying active. And some people, may say, well, I have a lot of arthritis, I can't do any exercise. There's pretty much something that everybody can do. It may not be as aggressive or vigorous, but maybe chair exercises, or just doing some stretches to start with. And if you do those every day, you can build yourself up slowly and then do more and more. I've seen it happen. I've actually worked in cardiac rehab too, and I worked with heart patients and seen patients that couldn't hardly move at all or do much. They were short of breath. And as they kept in with the program with cardiac rehab, they progressed pretty well. And by the end of 10 or 12 weeks, they were moving more, they felt better, they had lost some weight. So I've seen a lot of positive results from exercise, but you as the person has to do it. Nobody can do it for you, and that makes it hard.
And I think one thing too, and I'm not clinical, so everybody can chime in, but here again, we talk about the exercise. Remember, there's always pools too, and then you don't necessarily have to swim. You can easily just walk around in that pool, and you've got a lot of resistance. And I'll let somebody speak to that that's more clinical, but you can burn a lot of calories doing that.
I share time between the Diabetes Center and Health Point. I work over there too, and we help with people that are trying to make changes and lose weight. And they have a great team there that transition people from therapy over, and some young trainers that can help almost anybody move safely and not hurt, whether that's in the pool or with a very easy resistance type exercise. So it's a very comfortable place, and I left some flyers out on the back table about some of the services that we offer at Health Point too. So we have out there, without a doctor's order, you can see a dietitian or work with a trainer and a dietitian. And there's member rates and non-member rates. So you don't have to be a member there to have a meeting with a dietitian or with a trainer. So, and the pools are great.
Last part of this question is neuropathy reversible.
Neuropathy frequently is not reversible, unfortunately. I wish I could say otherwise. Once the nerve is damaged, it often does not regenerate. The primary focus in getting good blood sugar control is to keep it from getting worse. So when folks first start to develop a little numbness and tingling at the tips of the toes, that's usually the first warning sign. And some folks actually have their diabetes diagnosed by going to their doctor to see why their toes are tingling. They didn't even know that they had diagnosed diabetes prior to that. So usually it is not reversible, but the symptoms of it are treatable, and usually with good blood sugar control, we can keep it from progressing very rapidly at all. And I was actually going to expand a little bit too on the first part of that, as far as why blood sugars start to rise. But just because our understanding of diabetes in general has just blossomed over the past decade or two, we try to lump everybody neatly into type 1 and type 2 diabetes. In reality, there are probably 100 different types that we just don't know about. So there are all sorts of things that can make the blood sugar rise initially. Everything from the body's inability to make insulin, inability to release insulin properly, but excuse me, the most common type that most of us think about when we simply say diabetes is type 2 diabetes as it relates to what we call metabolic syndrome. Metabolic syndrome being a combination that usually involves high blood sugars, high bad cholesterol, low good cholesterol, high triglycerides, frequently high blood pressure as well, a whole constellation of things. That's what most of us think of when we simply say diabetes. In that case, it's really a two-hit phenomenon. The first issue is insulin resistance, where the body simply does not use insulin and sugar properly. And this can have onset in grade school, as early as that age. And then as that progresses, it involves a second hit to actually develop diabetes, which is the pancreas can't keep up. So you may have somebody who's very insulin resistant in childhood and even through adolescence, in their 20s and 30s, but the pancreas is keeping up. It's only when the pancreas can no longer keep up with that increased demand that the blood sugars start to rise. And so that's what most of us think of when we say diabetes, and that's when the sugars start to rise. And the best way to address insulin resistance is with exercise. A recurring theme.
Okay, are Crooks shoes okay for folks with diabetics?
What type of shoes?
Crooks?
Crocs.
Crocs. Sorry. You think
That's a man for you.
So typically we do not recommend that you wear Crocs for a number of reasons. Number one, they slide off your foot. Number two, they really don't have a thick sole. What that means is that if a nail or something were to go through the bottom of your shoe, you're not gonna feel it. And unless you happen to run your hand over the inside of your shoe, which is something that we actually recommend patients to do that are diabetic that have neuropathy, you're not gonna feel it. And it's gonna cause more damage than if you were wearing a thicker soled tennis shoe or a diabetic shoe. So to answer your question, no, we don't recommend you wear Crocs.
For Crooks.
Mike's got a new kind of shoe.
My daughter would be really embarrassed I didn't know that.
Okay, and this is along the topic of exercise. I've been told that walking and steps while at work doesn't count as exercise. Does 10,000 to 13,000 steps count?
Well, I would say that your body gets used to what you do every day. And so, even if you're a very active, say, construction worker or, a healthcare worker who walks 10 to 12, 15,000 steps a day, your body gets used to that. And as frustrating as that is, you still need to do exercise outside of that for most people. So, unfortunately, yes, what we do every day, our body gets used to. We need to do more than that. And it doesn't have to be a lot more like they alluded to. It's, 30 minutes, 5 days a week. And, one of the things I always like to tell patients is, look, exercise is free. So you don't have to go to a gym. Even walking to the mailbox and back and maybe, doing that again, that's more than what you were doing. And you can build on that. So you don't need to go out and train for a marathon. You don't need to do those things. But exercise is free. You just walk.
But on the other hand there too, if somebody hasn't been doing a lot there's 2,000 steps to a mile. So 10,000 steps would be like 5 miles. So for someone who doesn't do that normally in their job, that would be more than they could do. And in education, a lot of times we really like the idea of pedometers and counting your steps, because you have no one to beat but yourself, and you can have many goals that really can increase your steps. So every day, on your phone or on a little pedometer, it is very motivating and a way to push yourself a little bit. And sometimes people are only getting maybe 2,000 or 3,000 steps a day, so you try to get 4,000 steps a day, and you're close, but you're not there, so you take one more step around in the house until you get it. Or you can, you and your spouse can compete against each other and see how many you've got each day. So I think pedometers and step goals is a really good thing as a way to increase your activity when you haven't been very active or don't do that in your job normally.
I'll throw one in that's related to that while we're on the topic. For somebody that does exercise quite a bit, maybe even several hours a day, several days a week, is there an upper limit, or is the point where it's too much, or?
CrossFit? Are you talking about the high intensity?
I don't think it's CrossFit.
Well, if somebody, this is my experience with, for people that are trying to lose weight, people get real gung-ho for a while and they'll just tear it up, be really, really strict with their diet, just exercise a whole lot, but it's hard to sustain. So if you're losing this weight and you're doing 2 to 3, that's like Biggest Loser in some of those shows, they're exercising for hours. And as soon as you pull that back, you find the weight trying to creep back up. So, as far as health concerns, there might be upper limits as far as heart or blood pressure or things like that. But in my perspective for weight loss, it's good to find something that's sustainable and see it as pleasurable and not agony or torture, as a way to get things in order. So we all tend to get really gung-ho for a while and then fall off the wagon in about 10 to 12 weeks, whether that's with change in eating or exercise, and they pull each other. When we're being kind of careful about our diet, we tend to exercise more, and when we let one go, we let the other go. So they say exercise is the single most key important factor for maintaining weight loss, and it's the first thing that goes away when we get busy and stressed and tired. So it is the best medicine of all. And it's not just the calories it burns, it reduces insulin resistance for hours after you do it. So if somebody walks or exercises in the evening, they can actually continue to have a lower blood sugar all the way to their fasting blood sugar the next morning. And that is a great benefit. So it is so beneficial in so many ways.
From a cardiac perspective, though, there is a bell curve when it comes to exercise, which isn't a problem for many, including me, but but there is a bell curve. So, it gets to the point where, if somebody is exercising too much, you have the same risk factors as a couch potato as far as the heart goes. So, you hear about ultimate marathoners and different things, dying of heart issues. Well, yes, there's a bell curve. Most of us don't reach this end of the bell curve. And I went to a sports cardiology seminar that basically said, look, if you want to do a marathon and your doctor's okay with it, train for one marathon and be done with it. Otherwise, your risk factors for certain heart issues really do go up, believe it or not.
I recently talked to someone who had just ridden his bicycle 1,000 miles through the Rocky Mountains, and his A1C went up a little bit. And I specifically told him, don't try to go to 1,100 miles, it won't help. The 1,000 miles, if that didn't do it, the 1,100 won't either. So let's add a little metformin.
Wow, I did not know that. Okay, can any type of bariatric surgery help to decrease the need for insulin injection?
Bariatric surgeries have some pretty interesting and sometimes dramatic effects on glycemic control. There's sort of two phases to what the bariatric surgeries can do. There's sort of an immediate phase that not everyone experiences, and then the long-term phase. The long-term phase is generally linked directly to the weight loss. So as somebody loses the weight, their insulin resistance improves, and the doses of almost all their diabetes medications will go down dramatically. But what's very interesting, and I think we really don't fully understand this like we would like to. For at least, I would guesstimate maybe 50% of people, there's a pretty dramatic immediate effect. I've seen folks go into the hospital before with some pretty decent insulin doses to have their bariatric surgery and go out of the hospital without any at all. And it's pretty interesting, and it seems to have something to do with how that food is presented to the intestines and how it induces the body to respond to that food. Some surgeons even refer to it more as metabolic surgeries than they do bariatric surgeries. Again, not everyone experiences that. So then the next question, of course, for researchers is, well, what does people experience that other people don't? But almost everybody who has bariatric surgery will experience pretty dramatic improvements in their blood sugars. Now, long term, there is, with any significant surgery, there's a big risk of complications. So I'm not saying that this is some sort of silver bullet here, but a lot of people do get some pretty dramatic benefits from the surgery.
I think we found too that when they have bariatric surgery and how long they are on less medicine or no medicine depends on how long they've had diabetes when they get the bariatric surgery. If somebody's not had diabetes that long, it seems like the effect lasts longer. If somebody's been diabetic for a long time and has the surgery, it seems that they happen sooner that they will start to need medicine or insulin again. Whether you call that remission or reversal or whatever, sometimes seems to be related to how long they had diabetes prior.
Okay, why are classes not offered in the evenings for people at work?
Oh, I guess that's something we need to check into.
That's a good question.
Yeah.
Good question. It's higher up than our pay grade. We have security issues. It's night. We're small at the diabetes center. We'd have to really get some help on that. Somebody has said Saturdays too, but we've found that we can't do all that education in one long day. We need to divide it up to help people make changes and then follow them again. So that's a good question. I know it's hard to take off work sometimes for appointments.
Okay, this is another two-part question about cholesterol. Does cholesterol cause heart or chest pain? First part.
No, really kind of unfortunately, cholesterol is silent. So a lot of times I have trouble convincing patients to take medication for their cholesterol because they don't feel bad. They don't think they have a problem, or they think, just because my cholesterol is, they consider a little bit elevated, it's really not doing damage over time. I will also mention that, patients who have other things like diabetes, or hypertension, other risk factors for heart disease, even if their cholesterol isn't terribly elevated, it doesn't have to be very high, we might go ahead and put them on a cholesterol medication like a statin because we know that their cholesterol is eventually going to elevate, and we want to try to prevent that because cholesterol does damage over time. So.
Okay, and the second part of that question, what can you take to lower your high cholesterol?
There are several classes of medications that can be used to lower cholesterol. We really lean on the statins, there's a whole list of them, which fortunately now almost all of them are generic, which is great. We tend to lean on that class very heavily. They're very effective in lowering cholesterol, and they also have other what we call endpoint data, in that they've been shown to reduce risk of heart attack and stroke, even independent of their cholesterol lowering ability. So even somebody who has a good cholesterol to begin with, if they start one of these medications, statistically would have a lower risk of heart attack and stroke. So we tend to lean on that class of medications very heavily. They're highly studied, highly effective, and now they're really cheap, so that's great.
We also have patients that think if they take their cholesterol medicine, then they can eat their fried foods and deep fat fried foods, and it doesn't work that way either.
Absolutely not.
We had somebody say that this week, I think.
There are other classes of medications as well. There's one called ezetimibe. The brand name was Zetia, but it's now generic as well. It blocks absorption of cholesterol in the intestines, which is great, but it doesn't. It does lower cholesterol pretty effectively. It's lacking in the endpoint data. So you sort of have two camps of folks. Some folks say, well, it lowers cholesterol. We know that high cholesterol is bad, therefore it's a good medication. Other camp says if there's no endpoint data, why take it? I don't know who's right, but it's never my first choice, but sometimes it's either an add-on or a replacement for a statin for various reasons. There are other medications like colesevelam or colestipol, things like that lower cholesterol by different mechanisms. And then the newest class of medications are actually some biologic agents, which are injectable agents that are used generally every couple of weeks or even a month. They're highly effective, have, from what we can tell, virtually no side effects. They have great endpoint data. They're extraordinarily expensive. And so getting one of these approved through insurance, by my experience, is practically involves a letter from the congressman. So, I even read in an article one time entitled "The Greatest Class Medications You Can't Use." So those sort of encompass our various classes that we can use.
I would like to say about the statins, I'm going to bring up, yes, muscle pain with statins, right? That's going to be probably a question. I have to tell you that during the studies that they did on statins, myalgias were not as prevalent as people think. I think you hear the commercials, talk about rhabdomyolysis and all of these bad side effects, but statins are legitimately the only medication that we have in cardiology that have been proven to help prevent heart attack and stroke, two of the most feared things. So, patients are terrified of statins because they're afraid of getting muscle pain, or their mom got muscle pain on it, or their friend did. They heard, there was a rumor for a while that it caused cognitive issues, meaning, memory issues, and that was completely disproven. So I would say absolutely do not be afraid of statins if your provider is wanting to prescribe you one, because it is our only medication that has been proven to help prevent heart attack and stroke.
Okay, along with that, how can you lower your cholesterol if you're allergic to statins?
That comes back to diet and exercise, and I've seen dramatic changes with that. I had a lady, an example, that had a 300 cholesterol and couldn't take the medicine, and she lost 10 pounds. It went from 300 to 250, and then it wouldn't budge, and he said, we've got to find another way. And she goes, give me some more time. And then she started walking 3 miles a day, almost every day. And in the next 6 months, it went to 200. So she showed me how diet helped. And then when she added exercise, it helped. So both those things can help lower cholesterol. And weight loss does help lower all the numbers. The LDL, the cholesterol, it dramatically can bring down triglycerides and improve blood sugar. It helps everything.
Definitely, the diet and exercise are definitely the most important, without question. Pardon me. The other class of medications that I mentioned earlier, like the ezetimibe, the colesevelam, would also be beneficial in that regard. The colesevelam, interestingly, that's Welchol, if you're more familiar with the brand name, but that medication is actually the only one that's been shown to lower the LDL, the bad cholesterol, and actually lower A1C as well. It lowers A1C by about 0.5%, so it's the only medication that actually does both of those things. So it still doesn't have the endpoint data that we like to see, but I think it's still under the heading of better than nothing. So the brand name is Welchol. Insurance companies don't really like it either because it's not generic yet. But nonetheless, it's when you can get it through, it's actually a pretty good medication. It can raise triglycerides, unfortunately. That's one of the only, metabolically, one of the only downsides.
This isn't really a question, but I do want to just go ahead and answer it. There was a question, could the speakers stand when answering the questions so folks in the back can see them? The difficulty with that is we're recording this, the people couldn't come and watch it on the web, and if we have them stand up, we have the issue of trying to move the microphones and create background noise. So I apologize. We may take that into account the next time we have something that's this large and there are people that far back, so I'm sorry, but that would be kind of hard to have them do that and move the microphones. Can we prevent diabetes? Let me guess, diet and exercise.
Yes, that's pretty much what it comes down to. You can't change family history. Our joke in medicine is choose your parents wisely. But so you can't prevent family history, but you can at least put everything in your favor that you can, which is again the diet and exercise.
Okay. We've been talking about diet and exercise, so let's talk a little bit more about the foods that they should eat. Is there a good source that they can find on the web or anywhere else that they can look at so they know what to stay away from?
I think as far as evidence-based and what has been studied and been around for a long time is that Mediterranean diet approach. And you can look that up and find some good information about that. I have some here too, where you have lean meats and fruits and vegetables and whole grains, the things that you hear every day. You know, limiting simple sugar and sweets. And when somebody talks about carbohydrate and that effect on blood sugar, we limit the portions of bread and potatoes and starch and rice and pasta and things like that. But we're not in favor of eliminating that totally, you know. So that whole anti-inflammatory Mediterranean approach with olive oil, nuts and seeds and smaller portions of meat, more fish is just a good basic diet. But you can always eat too many calories of a good thing. So, you know, sometimes nuts and avocado and olive oil still has lots of calories. So somebody will say, well, I thought that was healthy, or I thought that was good for me. It is, but if you have 3,000 calories a day in those foods, you're not going to lose weight. So, you know, it's math at the end of the day, and how many calories it takes to hold you where you are is just, we're a mathematical equation. And to lose weight, we have to create a deficit. And so we have to take in less, even of the good foods too.
Okay, and part of this question is, and I think this is perfect as we're heading towards that great holiday called Thanksgiving, what is a good portion size for everybody to consider?
Everybody needs different amounts of calories, carbs, and food. So based on your height, weight, and age, that portion isn't the same for everyone. Most of us in Southeast Missouri eat pretty healthy portions of meat. So more reasonable portions of meat and less fried foods and seasoning and things like that. It's good to eat fruit, but you know, we talk about carbohydrate, and I have rubber food models at the diabetes center, and men tell me I live in miniature land when I show these portions, and we talk about that. So, you know, a half a cup of potatoes, a half a cup of corn, a half a cup of most things like that is considered one portion, but how much total you get at a meal or a day depends on how you arrange it, 3 meals or 3 snacks. There's no set way to arrange it. We arrange it to suit you and your lifestyle.
Just a similar question while we're talking about that, a question about some of these sort of diets we hear about, like keto and slim fast, or some of those kinds of diets.
I knew the keto thing would come up. Keto is a new version of the old low carb or no carb approach. And since I've been around so long, I have seen it go from Atkins to South Beach to paleo to wheat belly to now keto. So we joke about all of that, but this keto is, in theory, trying to put you in ketosis with a very high-fat diet, anywhere from 75 to 90% fat with 5% carb, which is very, very difficult to follow. In the old days, in research, it was used for treating epilepsy. So way back, there was a basis for that. But we don't think living in that state is good. You break down muscle and fat for fuel, and we never want anybody to lose any muscle mass, because then you slow your metabolism down. You can't sustain, none of them can usually be sustained for long. And at 6 months, weight loss usually stalls because you're still taking in a lot of calories. That would be I think limiting carbohydrate is good, but not trying to eliminate it completely. And some marathon, long distance runners, there has been times when people do that. There's ketosis and the real keto diet, and then there's modified versions of it. And most people are not really following that exactly. They're doing some version of that. And if you take one bite of a piece of fruit, you're out of ketosis. So we're throwing that word around, but it's just a new version of a low-carb diet. So that's very popular. It's not seeming to go away easily. It's just being touted a lot. I wouldn't recommend it. What do you think, Dr. Alcott?
Yeah, I agree completely with everything you said there. And what I see when people are on the keto diet, whatever version they use, however strictly they're following it, while they're on it, they do tend to lose weight. As Marietta said, they're losing muscle and fat, but they're losing weight. Blood sugars tend to get better. Surprisingly, the lipid profile may even improve a little bit, which makes no sense on the surface. But this is not a sustainable thing. When people do quote-unquote diets rather than lifestyle changes, it tends to be something that we try to push through. And so you do it for a month or 2 months or 3 months and try to push through this to reach some kind of goal. Well, what we see happen then is the moment that people stop doing this, all the weight comes back on very quickly. And so when people are doing this, they're losing the muscle and the fat. When they gain it back, they're gaining back the fat. So in the end, they've actually done themselves more harm than good. And so then you repeat this multiple times over and over the years, and in the end, you're the same weight you were before, but you have less and less muscle. So I really don't recommend any type of quote-unquote diet, if you want to call it that. Simply eating healthy and exercising more. And just to reiterate too that I think the healthiest single type is the true Mediterranean diet, like she said. Now that doesn't mean taking your current diet and adding olive oil and feta cheese. That means you really have to, for those of us that are used to the Midwestern diet, which I'm from here in Cape Girardeau as well, to truly follow a Mediterranean diet does actually take a little bit of research and doing, but that really is the best one.
You can get all the ingredients from the Mediterranean diet. I tell my patients this from Aldi's, which is something I like to reiterate, that it doesn't have to be expensive. So.
Mm-hmm. No, that's right.
Okay, what type of foods will reduce cholesterol?
No bacon, sausage, bologna, hot dogs, or pork rinds. I say that in my sleep at night. You can tell. Limiting red meat, limiting fatty meat, very lean, more fish, more grilled fish that's not deep fat fried with hush puppies and french fries and mayonnaise and coleslaw. Biscuits and gravy and bacon and eggs. I've done this a long time, and I often have heard Grandpa lived to be 100, and he ate biscuits and gravy and bacon and eggs every morning of his life, so why can't I? And you know why? It's because he was out working hard all day. They worked hard, they ate hearty, they didn't have McDonald's and Burger King and deep fat fried food, and that's just so bad for us. And so, we just need to limit fat and fried foods and just good lean protein. I don't know what you all think, but small portions of red meat is that's very lean is okay. If you can get tired of just living on chicken, but more fish and salmon is very good, and that's all part of that Mediterranean diet. You could talk more about that. Not much butter and sour cream and cream cheese, and you all know that. You know what that is.
So I need to quit my job at the hospital and get a job on a farm.
Need to plow those fields.
Yeah. What are the feelings on, I think it's Libre or sensors versus finger stick type monitoring?
Well, there's a lot of the CGMs or the continuous glucose monitoring are kind of what's surfacing, and that's what people want now. It's kind of a constant movement of your blood sugar. You see what that blood sugar is all the time. The finger sticks, you know, people get tired of poking their finger. It hurts. They forget to do it. They lose their meter. You know, the continuous glucose monitoring device, you put it in. It can stay in for 10 to 14 days. It's inserted under the skin, and it's measuring your glucose or blood sugar in your interstitial fluid. So it's the fluid around your cells. So there's a little bit of a lag time of your blood sugar from your finger stick to your continuous glucose monitoring reading. So that's always something to keep in mind. But I really like CGMs.
I like them. I like them a lot too. And we do have one for somebody coming to the clinic. We download it, and it fills in all the gaps, because no matter how many times you check your sugar, there are always those gaps in between. When it's high or low, we want to know what led up to that. And so when we do download the CGM, which you mentioned the brand name of the Freestyle Libre, it is pretty nice. You know, there are the more sophisticated ones too, like the Dexcom and things like that, that are really the Cadillac kind of model. But even the Freestyle Libre does fill in a lot of those gaps. And I think we've all found too that if you get a discrepancy between the finger stick and the CGM, probably the finger stick's more accurate, because it really is measuring blood rather than the interstitial fluid. But overall, they're pretty good.
Okay, I've got a couple more questions. I think you have, how many?
I've got a few more.
Okay.
I'll throw this one in because it relates to what we just did.
Okay.
Real quick. It's why do some people have to monitor blood sugar levels and others don't?
A lot of it depends on what treatment you're on, and you know, if somebody is on, just to give an example, if somebody is on just a single medication that really does not run the risk of low blood sugar, like let's say metformin, something like that, if consistently the A1C is fantastic, somebody's A1C is 6.0, they're really not going to get any low blood sugars from metformin. It's possible your doctor may say, you know, it's been good every time, let's take a break for a while. Somebody else may be on a much more complex regimen, on insulin, on multiple medications, and so in that case your doc may ask you to check once a day, twice a day, maybe 4 times a day. And so it sort of depends on the whole situation.
Okay, when your cholesterol goes down because of the medication that the physician has put you on, why don't they go ahead and take you off of that medication?
Well, the medication doesn't fix the problem, it just treats the problem. So if you stop the medication, it'll just go back to where it was before.
Okay, somebody whose husband, I refuse to believe this, I think men are being slandered here, but my husband will not go to classes. Why can't I, the spouse, attend if I would private pay and take the information back? Would that work?
Private pay without an order, you're saying?
With this, if the husband had an order but won't come, would it make sense for the spouse to come?
Insurance wouldn't pay for it, and so it wouldn't be covered.
It said private pay, so they would pay themselves. Well, I don't know if that's doable or that would make sense. Or...
Well, we usually write a note about who is educated and what, you know, the person that has the diabetes. So we could provide information.
I would suggest, rather than making that official with an order and education, that would be kind of just an information session that you could see me or Raina at Health Point and just get information and for a one-time charge, just get some information about diet that you could share with yourself and your family and your husband and anybody. It would just be kind of more off the record and just getting good nutrition information, including what we protect. So it wouldn't be in the medical record as part of the ad.
Okay, why doesn't the medical profession put more pressure on the food companies to not add the sugars in food?
Big business talks, doesn't it? Yes, that's a $50 million question. The medical, you know, the lobbying or whatever effort that is, has not a lot of influence over that. Money talks, and people are buying a lot of food. So we talk out both ends of our mouth. On one hand, everybody's supposed to be healthy, but then, you know, the bloomin' onion and an Aussie cheese fries at Outback and all these foods are being sold and people buy them, so they continue to do that. There's a lot of marketing and food research that goes into how to make people crave and want sugar and salt in foods. And they do that to make you crave and want more sugar and more fat. So you have to guard against it. You have to not use those foods and put them out of business. So that is, we live in a different time. 50,000 items on a grocery store shelf. There is, every restaurant, every fast food commercial, eating out. I mean, food is entertainment, and changing that is hard. I digress a little bit, but Mike Huckabee was the governor of Arkansas, and he was told he had diabetes and he was going to die if he didn't change his ways, and he lost 110 pounds, and he wrote a book called Quit Digging Your Grave with a Knife and Fork. And in that book he says, remember that food is fuel, it's not entertainment. Don't expect to be entertained every time you eat. It's medicine. Food is medicine, it's fuel. But we use it as entertainment every day, and so sometimes we tend to feel sorry for ourselves almost, that, oh, poor me, I can't have sugar, I'm not supposed to eat that, rather than, we try to empower people that, food's not the boss. I can have fun and enjoy my family. It's not about the food. Food is not in control of that. So the whole watching your diet is more of a mindset and wrapping your head and your brain around feeling good about that, rather than, it being a negative. And we work real hard at that. So it really isn't always about the food. It doesn't have to be. And that kind of leads to the holiday thing, because that's coming up and people are always worried about Thanksgiving dinner and Christmas dinner and all that. So I just say Christmas dinner is one meal. Thanksgiving is one meal. It's not from Thanksgiving through Christmas, through New Year's, at every break room and every event for weeks. That's what happens, and summer is just as hard. Weddings, anniversaries, parties. I mean, there's always, every day there's a reason to eat. The holidays are not that big a deal, just enjoy one piece of pumpkin pie, not 4, so enjoy it. Food's not the enemy. We're made to like and enjoy food, and don't feel guilty about it. If you have a splurge and get a high sugar that day, it can still be a good A1C over 3 months. You shouldn't feel guilty about that.
Okay, and we've been talking a lot about the diet and the exercise. Here's a great question I think we're getting through to some people. What is the best time to walk during the day? Is there?
I'd say whenever you can fit it in. It's got to work for you. You got to make it work. I know sometimes, I struggle to get my exercise in too, just like everybody else. Sometimes I'll come into work early and walk at the mall. The mall opens at 7. I go in at 8 to work, so I'll walk at the mall, or I'll stay after work and walk at the mall when it's cold, because I don't like walking in the cold. So, you just have to find what works for you, and find what type of activity or exercise works for you. There's lots of different options.
Moving after a meal can help lower blood sugar, right, when it's spiked.
Yeah, that's kind of what I was getting at.
Yeah.
I agree completely that whatever time of day you can get it in is the best time. If you can get yourself to do a little bit of something, even if it's just 5 or 10 minutes worth of something between supper and bedtime, that is beneficial. But now, having said that, some people that would really adversely affect their sleep. They'd have a hard time sleeping if they did that. So we're not trying to give you a bad night's sleep to get the walking in. But if it would not bother your sleep, then sometime between, a little bit of something between supper and bedtime is beneficial as well.
Mm-hmm.
I had one question that was asking about, are there any sort of gene therapy technologies or DNA repair technologies on the near horizon you know of?
If there are, I'm not aware of them yet.
And I've got one last question, and this is the doozy. I love it. Okay, so it says, I love breakfast. It's possibly my favorite meal of the day. However, I know I need to push aside my bacon, sausage, oatmeal, and such, which is so very hard. What's a guy to do? I gotta have a little more substance than a stinking piece of fruit. Looking for ideas for starting my day.
Oatmeal's good.
Marietta.
All right, oatmeal's good. Don't take out the oatmeal. A cup of oatmeal is 30 grams of carb. It's soluble fiber. Fiber is good. So I think oatmeal is soluble fiber and is the portion thing, you know. So don't put brown sugar and raisins and all
I
of
was
that.
going to say, are there some kinds, the instant and some of those that are so processed,
Yes.
are probably not as good as like an old-fashioned oatmeal?
Yeah, just cooked oatmeal is good, you know, and so eggs are good protein. They've gotten a bad rap over time, but they're high biological value protein, and that debate goes on too, but it's good protein. So sometimes just a bowl of cereal leaves you hungry in an hour, so a little something more substantial is good. So a real high fiber bread that has a lot of fiber in it to hold you steady when you do have toast is a good idea. And fruit's got carbs, so you don't want to just eat a meal with fruit only. It'll just spike you up. So putting some protein and carb together, a tablespoon of peanut butter, or some cheese or cottage cheese or yogurt with...
What about
that?
turkey bacon, turkey sausage?
No. Fat is fat, and turkey fat is fat too. So turkey hot dogs are still junk, so we don't want that. So they say if you saw a hot dog made, you never eat one again. I don't know if all of you farmers can tell me if that's true or not, but a couple pieces of turkey bacon would be better than regular bacon, probably. Yeah.
I had one other question, but I think you've addressed it in terms of the benefits of the diabetes education and support groups. And then there was a question about when the meetings are, and they have some flyers out on the table about that. So feel free to pick that up on the way out. But I think that addresses that question. So Gwen, did you have anything else? Or?
No, I think we can draw.
There's been some great questions, and I hope that worked out. I hope everybody felt like you kind of got what you came for. Again, there was challenges of having this large group, and I know the folks in the back, it's a little harder to see, but let's do our drawing before I get talking and forget.
Get your tickets out.
I'm gonna have Elizabeth, since she was so kind to fill in here, I'm gonna let her pick the winning ticket. Okay, the number is 518808. There we go. Huh? Do what?
Wait a minute, Roxy, did you have your?
Oh, I didn't pick your number. Okay, well, we'll have to talk about that afterwards. You need to pay the extra fee if you want a guaranteed win.
Roxy?
Yeah.
Did you have the number?
Yeah, she's got it, so we'll get it to you. Again, thank you all very much. And let's thank our panel for some great information. And again, feel free to pick up some information on the front table if there's some things they brought that are not in your folders. But thank you all for coming out.